see probably after the lecture today that I'm going to change that picture.
That's the open Microsoft.
All right, I guess we're just gonna dive in today in a series of just doing trauma. Interesting cases of trauma. It's more surgical disease than anything than medicine disease. So when you see trauma centers and everything else, this is more based in surgical fields of general surgery, thoracic, neuro, and orthopedics. Probably the most that you're going to see with traumas that actually go to surgery are probably going to be more orthopedic cases. Very seldom do we see intra-abdominal or thoracic type cases that go, but these will be the basis of what we see from the thoracic standpoint. Y'all have not had ACLS, I understand. Have y'all ever heard of ATLS? So, I guess back in the 80s, there was an orthopedic surgeon basically crashed a plane, went to a rural ER, and they fumbled around trying to take care of him. And, you know, he was still alive, understanding what was going on. He said, hell, I could do a better case than what you guys did here. They developed a course called Advanced Trauma Life Support. Okay? This is basically the steps to go through in assessing patients. And that's some of the things that you'll see when people come in. Probably in your first settings and seeing stuff, if you ever get to see any of this stuff, first thing to do is remember to just check your pulse. Okay? You probably have a coat around in the middle of your pants when you don't know what's going on. As you get more advanced and more knowledgeable about what goes on, you can slow down and think of what's going on. But the big thing in trauma, you didn't cause it. Okay? You just need to understand what goes on, what are the steps in doing, and it really is a 1, 2, 3 approach. You know, they talk about ATLS, primary survey, ADC, you know this, or you'll get this in ACLS, and there's D&E. Basically, you're just going over airways. Do they have an airway? Breathing, are they breathing? Circulatory, do they have it? B, what are the other dominions that are around the patient that have certain things, and E, the exposure. Expose the patient, look at them, and do things. And this is a very rapid assessment that you'll do in about 5 minutes. It's really just from head to toe, moving the patient over, keeping the C-spine stabilized, looking at the back. This would be part of what we see in thoracic surveys. The other things about the physiology of patients is knowing why you're doing what you're doing, okay? Shock. Anybody know the 3 things of shock? What causes shock? 3 things.
Hypovolemia.
Hypovolemia due to trauma, blood loss, GI bleed, you know, that's one of them.
Sepsis.
Sepsis is another. Infection is a major cause of it. And the third,
Hemorrhagia. You have to-
cardiogenic. Okay? So when you think of these 3 shock values, they're treated all differently. Okay? If you treat one, but it's another, you cause problems, right? Hypovolemia, what are we going to do? Give them fluids, give them blood, right? If they're cardiogenic and the heart failure, you give them fluids, you give them blood, you're going to kill them. Okay? So these were pressors or mandate of certain drugs come into effect, especially with sepsis, especially with cardiogenic. You're going to start thinking about dopamine, dobutamine, Levophed. You'll hear the expression of Levophed, leave them dead. But pressors are meant to do certain things, improve cardiac function, improve perfusibility. Sepsis is an all-out systemic effect. And we'll talk about some of these things in here. I don't know if y'all have heard of SIRS criteria. I don't know if that's been mentioned to y'all
Coming in
before.
peds, that'll be part of your sepsis.
So,
lecture and
you know,
workshop.
a systemic inflammatory response syndrome, that's a big thing in the ER, regardless whether it's trauma or infection. Someone comes in, their vital signs are all over the place, they're febrile, they're tachycardic. You start getting things called lactic acid. Lactic acid's a big thing that we look up for SIRS and sepsis. these people are very sick, will need pressors, antibiotics, and so forth. You know, dopamine is a very good drug for sepsis. Okay? Improves heart rate, contractility, quenches down the blood system, gets blood pressure back where it needs to be. For dobutamine, similar to dopamine, in higher doses, reduces blood pressure. In the beginning, it will jack up blood pressure like dopamine, but when you get into higher doses of it, blood pressure starts to fall off. This actually improves cardiac output, right? Gets blood out of the heart easier, gets the heart rate up. So in cardiogenic shock, dobutamine is one of the first drugs they're going to go to. Okay? This is a critical point because I've seen this one time in my career, actually when I was doing cardiology back in Tulsa. We had a septic patient, gastric bypass, got peritonitis after surgery. We had actually on 3 pressors, dopamine, dobutamine, and Levophed. All for different responses, you know, for norepi, the adrenergic receptors and all that. But anyways, we got them off the Levophed. We got them off the dobutamine, we got them back to dopamine, and we had them at 18 mics. And was weaning it down and probably going to get her off of it within a day or so and have that patient go home for about 2 days. New nurse didn't understand what she was doing. Hung dobutamine instead of dopamine. Dropped the pressures, heart rates went up, she wasn't sure what was going on, panicked, called the surgeon. He didn't know what the hell he was doing, gave him Levophed, constricted the vessels and everything else, shocked her liver. Their functions went 10 times normal. The patient died. Should have been home in 2 days, but went home in pine box. So, I mean, these are important things about what you pay attention to and what you're doing and what your mathematical responses are, what you're thinking through and what's going on with the patient. Okay? So those are just some things I've seen that you got to understand some certain physiologies, but always be thinking about what's in front of you. Take your pulse, sit back, and review the system, okay? Because when trauma comes in, I promise you, things are going sideways quickly and everything, okay? Especially in serious trauma. So when you have serious trauma, some patients just die. You know, happens. But you don't want it to happen because of you, right? And make sure you're decisive in what you're going through. That being said, we're going to go into thoracic. So they just want you to understand general anatomy, obviously. You need to know when it's life-threatening and not. Discuss the ATLS guidelines, appropriate interventions, and things of that nature. There are complications that, you know, obviously arise from thoracic trauma that we'll discuss and go through.
Is it on?
Be on.
You gotta turn on.
We'll, it's on.
Try the keyboard.
And I second chance. Use the arrow key.
The keyboard?
Keyboard. That's what we're doing.
Oh. Sorry.
I didn't do anything. I just stay in there.
How did you get to that side? It moved once.
All right, so that's the
Do it. There.
All right.
That's right.
So right clickety, is that what you said? All right. So thoracic trauma, left click. All right. Thoracic trauma, it is a significant source of morbidity and mortality in the trauma victim. Okay? With blunt trauma, you could probably get, depending on the severity of it, 7 to 17% of the mortality. Okay? But morbidity, things that get caused secondary to the trauma. Okay? These things escalate a patient to die in the hospital. They can go up 33%. We'll talk about those things. But you know, people who get pneumothoraces, or they get pneumonia from their blood that's in their chest, empyemas. Everybody know what an empyema is? Have you ever seen them? They're nasty. Very, very, very bad for patients. You know, it is about 20% of all trauma admissions. Less than 10% though really are not surgical. Like I said, probably more orthopedic stuff's going to be seen. And most of these that do go to surgery are going to be penetrated. Okay? Obviously, if you got something that sticks through your chest, that's probably not a good thing. You probably need some type of surgical correction. All of these we will be discussing today. Rib fractures. Some people think, oh, it's a rib, you know, not a big deal. Well, get a flail chest. We'll talk about why that's significant. Pulmonary contusion is a bad deal. Okay? Bruising of the lung, not a good thing. If you've ever seen pulmonary emboli, pulmonary emboli kill people, contusions kind of act the same way physiologically. Pneumothoraces, obviously, they can be problematic. You know, you need your lungs inflated to breathe. Pneumothorax, penetrating trauma, talk about thoracotomy, you know, big all knowing, cut someone over, stick your hands in their chest and save the life, right? You know, everything on TV that shows that they survive. Huh. Yeah. You're doing that, you've got a bad case. Chest wall, you know, obviously you've got your bony cages that comes around, the ribs, the spines, everything that connects, articulates. Sternum, scapula, clavicles are all part of this, okay? But the intrathoracic aspects of what we're looking at is what we're really concerned about, okay? You know, the lungs, the trachea, the bronchia, tracheal lacerations are bad things, the esophagus, great vessels that sit in the middle behind the sternum, thoracoabdominal considerations. Remember, your spleen, your liver are up underneath the rib cage, okay? Colon, stomach, and all those other things can kind of get you. This is just kind of the overview of what we're looking at. You can see the bony structures, the lungs, trachea, they're showing the spleen, the livers. I think this is all pretty much understanding of the anatomy by now. Y'all have got a human body over there. Again, ribs, how they articulate. Rib fractures associated with severe pain. No kidding. Probably one of the most common fractures or thoracic injuries that we'll see, whether it be severe trauma or not. Someone gets a rib fracture, they come in, they're just hurting, they can't breathe and everything. One of the worst things we ever did for people is kind of put them in a tourniquet. Actually found out that was way wrong, right? So problems with it is that people don't want to breathe. They don't expand their lungs. They get what's called atelectasis, distal collapse of the lungs, gets into pneumonias, gets into problems. Okay? This probably should go without saying, the more ribs fractured, the more severity the problem can be. Okay? Usually, hygiene of lungs is usually kind of recalled. If you got more than 3 rib fractures, probably a pulmonary spirometer is used to help kind of get that distal airway opened up. Okay? Pneumonia is a big thing with that. Flail chest is a bigger thing. Okay? Anybody ever seen a flail chest? Basically, you have the structures of the thoracic cavity. And basically, what is it? It's a series of muscles expanding and contracting to inflow air and exflow air. Actually brings a little blood into the heart and lets blood go out of the heart. Okay? So if you've got a series of fractured ribs in 2 or more areas of greater than 3, you basically have a flail chest. Okay? Basically, you've got a section of ribs that were just blasted out and no longer work in harmony with that pump action of what the thoracic cavity should do. Okay? You kind of get a dismantlement of lung functions. Okay? You can no longer expand the chest and contract the chest with the diaphragms, muscles, intercostal muscles, and so forth to breathe. It's a big problem. The other thing about it is rib fractures. Ribs are a big significant place of blood. They can bleed significantly into the pleural space, cause hemothoraces. They're sharp enough and penetrate far enough in the cavity, it'll take out a lung, cut it, lacerate it, drop it. Bad things. Contusions, obviously, if you get that much blunt trauma, think about the force that it takes onto the lung itself. Bruising of the lung, again, is a bad thing. Prolonged morbidity, chronic pain, respiratory insufficiency, this is a problem because people don't want to breathe. The older they are, pneumonia is a bad thing, and pneumonia kills. I know we take it for granted in some aspects of this in this country, but pneumonia can be a bad, bad thing, especially with these bugs nowadays out in the field that are resistant to antibiotics. But you'll also get, you know, what we're talking about, the SIRS and sepsis. Systemic inflammatory response is just not just like what we're talking about at the lungs. You get an inflammatory response in the body, it'll kill your kidneys, it'll kill your liver, it'll attack other aspects in multi-organ failure, and people die from this. Okay? So this is something that is major concerns for. Occasionally candidates can be surgical repair candidates. And actually, they've had some studies that actually show reduction in morbidity and mortality because you stabilize the fracture, you stabilize the pain, people have less pain and less problematic. It's kind of interesting what they do. It's down there medieval looking for how they repair them, but they have shown actually great strides in helping with patients. Yeah, they're showing you a rib fracture off to your right there. Flail chest, again, classically 3 sequential rib fractures in 2 or more places. Hypoventilation is the biggest thing. You can't expand the lungs, you can't breathe, you can't oxygenate. Okay? Paradoxal chest movements resulting in insufficient ventilation is a big thing. This becomes determinant upon, do you need to mechanically ventilate this patient? Have y'all ever seen airways? Have they practiced airways? Intubation is another thing, okay? You have to take a step back, breathe, and understand things. Anybody know what RSI is?
Say, rapid sequencing.
Do you know what transforms in RSI? Okay. Rapid sequence intubation, RSI. They'll call for RSI drugs. This is very important for what you do when you assess an airway. If someone's got hypoperfusion or can't maintain an airway, or you think they can't breathe, you have to maintain that airway by any means. There are several different ways that you can do it. You can do it through non-invasive pressure ventilation, okay? CPAP, BiPAP, okay? These are very good modalities that is not very invasive to the patient and can be effective. Actually, studies have shown that CPAP has improved morbidity, mortality in patients with COPD exacerbations, as well as CHF exacerbations. Okay? Reduction of hospitalizations and morbidities and mortalities related to the function of the failure. Okay? But RSI is a significant thing, and it can be scary as hell. You miss an intubation, the rate of death goes up 40%. 40%. So RSI basically starts out with ventilating the patient and pre-oxygenating the patient as best you can. Get the pulse ox up as best you can. okay? Sometimes you might not have the time to do it. If the patient is responsive or alert, then you have certain drugs that you have to use, okay? It's not fun being intubated, okay? Drugs I like to use, Versed's the first one, just because people don't remember afterwards. They get it, you just get an anemic type response to it when you give it. I usually give about 5 Versed IV, okay? That one relaxes the patient, and 2, it also calms them down, because when you start to use paralytics, which is the next drug coming, if you use SUX or succinylcholine, they fasciculate. That's not fun. You'll literally just see them just start shaking, okay? Then they're out, but they're awake, okay? It's not fun to be paralyzed and knowing you can't move a damn thing or do anything. At this point in time is when you go in and do the intubation and you use your MAC or your long blade and put the ET tube between the vocal cords, okay? There are some other drugs like rock, petronium. It's longer acting, they don't fasciculate as much, but plausible. But once you can get them stabilized, you get the rapid sequence in, you get the intubation in, things are fine, you can do it, then you can move on to do venting. And from what I understand, you're going to get some vent lectures coming to you and stuff. And, basic things to do is know your tidal volume, right? Don't set it to 1,000, right? Blow the lungs out. You know, usually about 500 tidal volume should be sufficient. You'll have to understand rate, FiO2, you know, oxygen toxicity is a significant problem, okay? If they're ventilating and you can take their FiO2 down to 60% and they're still oxygenating above 92 on the pulse ox, that's a good thing. Don't keep it at 100%. Ventilatory rates are significant. You know, some suggestions in what we'll talk about later on, like people in ARDS, they've gone to different type of things of trying to do higher breaths with lower pressures to ventilate, to cause less barotrauma to the lungs. How long does anybody know how long you can keep someone safely intubated? Does anybody know that there's a time frame that you have to get them out extubated? Anybody know why you have to extubate them?
Risk of infection.
Tracheal eclexia, you know, when they get it, they'll get fibrosis of the trachea, and then they can't breathe. So usually about 4 weeks of intubation with that inflation tube in. If you're going more than 4 weeks, you're going to start seeing someone get trached. So usually about 3 weeks in, you're going to start seeing probably someone calling an ears, nose, and throat doctor to come intubate or trach this patient if they're going to need to be on a vent longer than that. Otherwise, they're not going to survive. That's a bad thing. Tracheal stenosis is not a good thing to have. Okay? That's just an FYI thing. All right. Contusion and underlying lung hypoxia and increased shunt fractions. You understand shunt fractions and things? Is anybody talk physiology of it? So blood comes in, blood goes into the lungs, goes into your capillary beds, oxygen comes in the tracheal beds, you get inflow and outflow, okay? But if you get blood that goes into an area that cannot perfuse, you get hypoxia, okay? That's a problem. That's what we call shunting. Pulmonary emboli does the same thing because it keeps blood from able to get there to oxygenate, okay? With this, you get lower ability to get oxygen in and out of the body appropriately. You shunt large enough to get a saddle emboli, you die. You get a large enough pulmonary contusion, you can die. Okay? You know, just like in ARDS, everybody know what ARDS is? I keep throwing that term out. Acute respiratory distress syndrome. You get enough ARDS that reduces the ability to get blood or oxygen into capillary beds. You lower your tidal volume low enough, you can't get enough volume in to survive. And these is what we're all talking about shunting, okay? That's a major problem. Sometimes we can't overcome it. You go into ARDS, anybody know the probability of death when someone gets ARDS?
50%?
About 50%, depending on what it's due to. If it's infectious, or if they have other multi-organ problems, like kidney or something, it goes up to about 80%. It's a 20% chance of survival. Significant. Sometimes we can't prevent it. Ventilating the patient can put somebody into ARDS. So, it's a significant thing to always think about when you're doing things of that nature. Ever see you see the deformity on the left or right side of this patient? See how the chest kind of falls off? The upper chest is up, the other one's down. Okay, it's crushed in, can't do anything. It's just kind of showing on the other side that the lungs are down. That's flailed chest. This is kind of just a depiction of it. This is an actual X-ray that you can see. You see the disruption here through there, all the soft tissue, bony. You don't see the continuity here. It's a bad thing. Yeah, the National Trauma Data Bank evidence and stuff with it. And, I mean, this goes without saying, right? The more rib fractures you have, the worse the probability of something going wrong, right? So the mortality rate per rib ranges from 1.8 to 3.2% for each rib. The more ribs there are, the higher that probability goes up, right? And that's due, you know, with advancing age. Can the elderly sustain this? No. You know, pneumonia, it kind of goes without saying that more ribs that are fractured means there's more penetrating or blunt trauma to the chest. Obviously, you can get underlying disease of the rib or lungs and great vessels and so forth. I mean, it kind of goes without saying is, again, you know, the higher the force to the chest, more ribs going to be fractured, morbidity, mortality because of pulmonary death or pneumonia or something is going to increase. I mean, this kind of beating a dead horse with this. But 6 or more rib fractures, that's a pretty bad one. If you see the first, second, or third rib broken, that patient has sustained a significant trauma, okay? It's easy to break probably 6 through 12 because these are longer ribs. You ever seen, you know, the first rib, how short and thick it is? The trauma it takes to break that is significant. Survival of that kind of impact is very low. Trying to treat the underlying conditions with this, I mean, obviously, respiratory support if needed. If they've got a flailed chest, obviously, you know, do we need to intubate them or not? You know, are you going to go through all your RSIs and so forth? Appropriate resuscitations are the appropriate things. If you need to protect the airway, protect the airway. Good. The biggest management with it is pain management of these people. Sometimes we do epidurals on them. Sometimes we just do local anesthesia to them to maintain that it's been shown. But early mobilization, getting people up, moving around, doing things are going to be treating underlying injuries, you know, with the lungs and so forth. The operative fixation seems to be very good with fixing the lung or the ribs and keeping them from being painful. So, again, ideally, epidurals are great treatment options for it, like we're talking about curvy vertebral anesthesia, just injecting at the sites and blocking the nerves that are coming out and going to the pain areas. Aggressive chest physiotherapy, you know, whether it be pulmonary spirometers, or, you know, whether you need chest percussion therapy due to pneumonia and atelectasis to get them going. Diuretics, I mean, these things are there, but they're not as much. This might be due to aggressive volume that we give a patient in the amounts of resuscitation at the times that you might have to be diligent about thinking, you know, we need to watch volume overload on these people. Sometimes we force a lot of fluids in, especially with blood products. Yeah, the paravertebral, they're just saying that if you can do the blocks and stuff, this could be as equivalent to epidural analgesia as well. In some of those cases where if you have penetrating injuries that go back that really don't allow you to actually put an epidural in somebody. Epidurals are interesting creatures. You actually have to have a stable patient to be able to roll over and bend them and do things. Anybody ever seen one of those done? Epidurals done? Anybody, any women give birth yet?
I had one. Didn't watch it.
What'd you think of your epidural? Fun?
No. It wasn't as bad as I thought.
No, but think about if you got a penetrating chest wound and everything else. And this is basically an epidural. Is just what it's talking about. You're not entering the dura itself. You're just going right on top of it, but you've got to get into an area between the vertebrae and the dura mass itself. Okay, so anybody know where you put that or eject it into? Anybody know what area of the back you go into?
It's between 2 and 3.
Where?
Or no, I'm sorry, L5 is what my brain is
A little higher.
thinking.
Between 2 and 3.
Okay. That's usually when you're going to do it. You feel the pelvic rim right here. Bring your thumbs across. You can feel it. Okay. When you do the injection, and this is just for my neurosurgery days here, but you know, so you have your spine, right?
This is where you do a little.
And then this is where the lamina come out. You have your little things there. So you have a ligament that goes right across here, right? Okay. So you want to get into this space here, right? You're going to come straight down that path. If you come down the spine, so you feel the spinous processes, you want to try and get in between there, because if you don't, you're going to tap this and you're going to keep tapping it, and the patient will be jumping off the bed and doing everything, screaming every foul word they can probably get to you. You want to do it because the reason that you do it at this area, anybody understand why we picked this area? Where does the spinal cord end? Correct. You don't want to paralyze somebody or do sufficient damage to them. So you basically just drive the needle in. You know, if you're doing a spinal tap, you drive it all the way in, pull it out, get spinal fluid, and do what you need to do. But they usually just drive till they get, there's a ligament here called ligamentum flavum. Anybody know what I call ligamentum flavum? No? Correct. It's a yellow ligament. When you look at it, it is. The damn thing is yellow. I don't know why, but flavum, that's yellow. So, but you just feel that pop that goes through there. You have the dura that sits in here, and then they just put in all the medicine that will seep across and into the nervous areas and stuff. So that's, you can do those epidurals. But for these that we're talking about, they're going to do it higher up into the kind of neck area to actually intervene and do things down. So I mean, it is a significant procedure that is need to be watched significantly, because you can do damage to the spinal cord. But, oh yeah. But even in my 20+ years practicing, there's no way I've got the balls enough to try to do something with that. That's going to interventional radiology or somebody. Ventilator guidelines, again, they're talking about CPAP, non-invasive pressure. People that are awake, have a protected airway, but still needing oxygenation. This is one of the best, and I cannot repeat this, one of the best things to do for a patient. just force air into their lungs. It does well for them. So,
Yesterday, when she was giving you your lecture over asthma, I so bad wanted to go into that, but
what's
he's
that?
covering it. So, Dr. Latassi.
She had talked about
She
CPAP,
talked
about that?
about, as far as when you're having a complication with asthma and their CO2s going up, you blow that off by placing them on CPAP or BiPAP to prevent, hopefully, from them having to be intubated.
She showed some videos of them doing that.
Oh, good.
Yeah.
Wonderful ones before I got here then. Okay.
Yeah, I can't tell you how many times in the emergency room that I've had elderly patients come in, they're wheezing, they can't do anything, I just CPAP them, the next thing you know, I barely got them on any oxygen, and they're blowing fine, and I pass them off to the internist and say, have fun. It is an absolutely godsend as far as not having to intubate one of them. Because if you've ever tried to intubate an asthmatic or a COPD who's stressed out, it's not fun at all. Not fun. Pulmonary contusion, flail chest requiring mechanical ventilation. Again, there is other things. Y'all know what PEEP is? Y'all have heard of PEEP? Yeah, so at the end of it, it pushes, it's kind of like a CPAP, it pushes a positive end aspiration to keep things open, okay? You get too much PEEP though, it can cause barotrauma. Again, that can cause you to go to the heart as well. So it's something that you just got to keep aware of. And you know what? Sometimes you just can't. You got to bite the bullet and do it. You know? Sometimes you just go with it, and you know what? You tried, but they die anyway. Like a surgeon once told me, you can't be afraid to kill people because you're going to do it. Might not mean to do it, but it can happen. You know? These responses, what you do. You know? Sometimes you just can't help. High frequency oscillatory ventilation is kind of an interesting concept. Some hospitals have their own criteria how they're going to do this, and basically these are techniques to increase respiratory rate, decrease tidal volumes and stuff. I mean, speed someone's respiratory rate up to like 60 a minute, you know, with low tidal volumes to try and improve things. This is seen in like ARDS patients and things of this nature to see. They do increase oxygen to the patient, but it's not been shown to be beneficial. So it's very controversial what they're doing and how they're doing it and stuff, but sometimes they're using it to do it. It seems to combat the shunt factors of some of it, tidal volume loading, but not always do they seem to be effective. You know, there's no studies that actually say this is something that we should be doing or going to. So, and again, you know, it's somewhat problematic. You know, when studies, and I mean, I don't know how much has been proven on to y'all and stuff when you look at certain things, but in medicine, there's a lot of things that we do that's called evidence-based, right? We do it because this is what it shows us that we do. Back in the days when I was studying, you know, we didn't give beta blockers to diabetics. It was malpractice. Anybody know why that theory was out there? It looked like we disguised the hypoglycemic aspects that a patient was going to have. You know, it's malpractice not to give them beta blockers now, especially with heart disease. Heart failure, we didn't give them beta blockers. That was another big one. That was a big no-no. How stupid were we? Well, I wasn't, because that's what they were teaching me. But anyways, it just goes to show you that things are going to go around and come around, and things will be fashionable one time and not. Your job is to do the practice of medicine. And that's what it is. It's practice. It's not a science. We do a lot of science crap and this and that, but sometimes you just don't know. Okay? So there'll be studies out there that will kind of show you. But point back being is that I'm getting back to this high frequency oscillatory ventilating type stuff. It's really hard to do certain things in studies because it really is not appropriate to get the best study possible, right? You get somebody in here and we're saying, well, we're not gonna do anything for him because, you know, hell, who gives a shit if he dies? Well, we're gonna do everything for this patient, then we're gonna compare the two. Morality doesn't really tell us that we can do that, right? So we just confer on our basis of it. That's why I'm saying, you know, and sometimes you can't really constrict therapy from somebody, even though if we know it is, okay? So it's hard to set up certain studies to then demand where we go for certain things. So the best things you can do is just read a lot, see what some of the experts are saying out there, if they are experts, but then use your knowledge and the base knowledge that you'll gain in making your own decisions. And that's what we call the practice. In the beginning, it'll be terrifying. Terrifying. All right, so these are some of the other things they show. Doing traction, this is barbaric as hell. Some places still do this, believe it or not. Anybody want to be hooked up like that? These are the newer advancements in rib fracture relocations and stuff, and just splinting them. These are extremely successful indications for people, especially with these flail chests. That's a major surgery there, and I cannot express to you all thoracotomy. Anytime that you go into a chest, the patient afterwards, for the rest of their life, are going to hurt like hell. One of the most painful incisions you can ever give somebody is thoracotomy. Whether you put a chest tube in, whether you crack their chest or massage their heart or whatever you're doing, that is a painful incision. Okay? So these type of surgeries that have actually shown by stabilizing the ribs and not really disrupting as much of the pleural aspects that you get, have shown improvement, morbidity, mortality. People are in the hospital less, they don't get pneumonia as much, they don't get infections as much, they don't go into ARDS, they don't get SIRS. It has been absolutely beautiful for what these little things can do to somebody. I guess we get it myself. So this is just the data that shows that, you know, this is demonstrating incidence of pneumonias, less vent days, decreased mortality in operative groups. Okay? Prospective randomized trials, again, this is just telling you, you know, it's hard to say who gets something or not, but you can take in these studies about people who didn't have the indication to have surgery or couldn't do it that had these compared to those that did. And they randomize this and look to take out the bias of the people who are doing the studies and stuff and seeing what it comes out to. But it's still, I mean, I think it makes sense. Stabilize the fracture, guess what's going to happen? I think you're going to do better. My opinion, if it were me, drill them, put them in there, right? And again, these are just some of the things stabilizing. You can see that stabilization, chest infections are much lower, vent days are lower, ICU days are lower, basically lower days in the hospital. Okay? Stabilized fracture does better. That's why orthopedics always love to do surgery. They like to make money. Again, long-term results in groups 1 and then 2. One's operative groups do much better than non-operative groups. Again, biases that you get. Pulmonary function, pain, select patient populations are better. It's not for everyone. Some patients can't get the surgeries. Okay? Older, frail people who have osteoporosis, they can't do it, can't take the injury of the surgery and stuff, you know, you can't always do it. Severe polytrauma patients, you know, this is that incidence where, you know, these people are very, very sick. They've got surgeries all over the place, you know, causing another surgery or doing more. Really didn't have benefit in some of the studies. So You know, you need to stabilize people as best you can. These are the people who, have, double femur fractures, their arms are broke, their back's busted, they've got thoracic injury as well, pulmonary contusion with a flail chest, that have intra-abdominal, lax of their liver or something. These patients, I mean, you're not gonna do this on them. And their survival rate's not gonna be that high to begin with. Okay. Pulmonary contusions. All right. Obviously, perfusion mismatch, what we talked about earlier, shunting of oxygen because you can't get it into the blood, right? Can't get airways down, your tidal volumes are out, you get hypoxia. Not only will you get an immunological response that when you cut yourself and you do a lot of things, that's the first thing that's going to go, is that you're going to get an immunological response due to cytokinins, due to proteins that are out there that say, hey, you're damaged, we need to come. When these markers get there, the body gets inflamed, right? That's why when you cut, you hurt, right? Just like if you were to have a heart attack, what happens? Plaque ruptures, platelets start aggregating, inflammatory response comes, cut the blood flow, broke over a heart attack, right? It's the same thing with pulmonary contusion. But it's significant enough in the lungs that it will create a body-wide systemic inflammatory reactions, or the SIRS, okay? That is significant. These aren't septic patients. You're not looking for a lactic acid or something of that nature to see how anabolic they are with certain things, but it is directly involving the alveolar capillary membrane. But these complexes can also go and attack different organs, kidneys, liver, so forth. It's just not located to the lungs, especially how bad it be. And then if it's significant enough, you can get acute respiratory distress syndrome, and then you're in the world of hurt. ARDS is a bad, bad scenario. Anybody ever seen it? Anybody been in the hospital, seen patients with it?
My grandpa was actually in ARDS, and he passed away. But it was ventilator-induced ARDS,
Yeah.
and he passed away.
You basically go from a clear-looking chest x-ray to a totally whited out chest. It is not pretty. Not pretty at all. Pulmonary PT hygiene, trying to keep, if they're intubated and doing things, obviously you're not trying to get them infected or doing things, but spirometry is always a good thing to do. Positive expiratory PEEP is a good thing to help kind of get that airways open and stay open, especially if they have the capillary reduction. CPAP, to me, if they're conscious and awake and they're able to do things, CPAP is a much better delivery system than intubating somebody. It always should be tried first. Always. It's less invasive to the patients, and it's not going to be as prominent. Y'all seen these CPAPs, haven't you? These damn masks look like fighter pilots and stuff. And people, and you're like, I can't understand damn word you're saying. You have to take that off. But, the airway gets forced out, right? If you ever listen to it, you can hear it escape through the sides of it. And you've got an ET tube in there that's inflated in, and you're pushing that pressure in there, and guess what happens? That pressure's not relieved. It's going all into the lungs and causing significant problems. So CPAP is always a less non-invasive type thing, so it is a very good modality. I would not hesitate with any of it and do it anytime. Okay? Judicious use of IV fluids is always something. Keeping the circulatory volumes going and making sure they have enough blood to carry the oxygen. Okay? You might have to diurese your patients at times, depending on what your kidney functionality is and how much glomerular filtration rate you have. You gotta be careful though, because you can throw them into volume overload, but you gotta keep volume going in these patients. Okay? Y'all like this chest x-ray? That's pulmonary contusion. That's a bad one. I mean, I would CAT scan that anytime I see that, just to make sure, one, I've seen pulmonary emboli of this nature. Okay? That's a bad one. That usually kills people if it's pulmonary emboli. Pulmonary contusion, though, like that, that's a bad one too. How much oxygenation you get? You can see all that up into the CT there, right? How much ventilation you think's going? I mean, she damn near has lost all of what? Maybe, I'd say a good 45% of their ventilation tidal volume. That's hard to keep someone alive. Sometimes when it gets bad enough, one of the tricks that can be done, and usually is you'll require probably a pulmonologist to come in, but you'll do single lung intubation. You'll take it all the way down to the bronchial. Get out of the main stimulus. It's tricky sometimes, but I mean, it can happen. But this is a bad scenario. This patient's in trouble. They're going to be in shock. You know, they're going to be bleeding. You're going to get blood. And that brings up another question. Someone like this, who's bleeding out in a hypovolemic or traumatic situation, who would want to give them pressors? I'd stay away from them. Okay? I would not use them if at all possible. Okay? They're not hypotensive or shocky for unreasons. They've got enough adrenaline and steroids and stuff that their body's kicking out to try and get things going. What they need is volume, and they need volume quick. And if you're constricting vessels and everything else to jack pressures up, you're going to shock end organs. Okay? Just like the reverse is true cardiogenic shock. We're not going to push a lot of fluids because we're going to put it all in their lungs or cause some other problems. You want to give them pressures to get things going, to get the physiological effect of the heart, the blood vessels, and everything else. Okay? So these are just dynamic things that you think of. Why are you doing what you're doing? Okay? What's the physiological effect that's going to happen if I do this thing to this patient or do this thing to this patient? Okay? Not to say that people don't put pressures on there. I mean, sometimes, if they're bleeding out and they're doing everything possible and you still can't get things up, I mean, it's problematic. Pneumothoraces. Every surgical intern's wet dream right there, right? Every time they see a dropped lung, oh, we'll put chest tube in. Not every pneumothorax needs a chest tube. Okay? Patient's stable, the vitals are good, they're oxygenating well. You keep them on oxygen and see if it reduces itself. Okay? Sometimes it doesn't. Okay? If it's due to trauma and it's down and they're getting tensions and stuff, then you're going to have to act a little sooner than not. If their oxygen's not staying where it needs to be, well, then you might need to do something. But there's no doubt, if it's an open one, it's getting a tube. Sucking chest wounds are not a good thing. And when you see them, you know why I call them sucking chest wounds. Okay? So, tension, obviously, is a bad one. Okay? That's the one that kills immediately. Okay? I've actually seen people miss it. And you'd think it wouldn't be that difficult, but it can be quite difficult. And just a simple needle decompression can save a life just like that. But it's not always as obvious as what most people think. Okay? Sometimes you don't see the deviation of the trachea. Sometimes you don't see the distended neck veins. Yeah, you have decreased lung sounds, but you know, that could be due to a number of things. You don't see obvious trauma to the chest, but the pneumothorax there, and then next thing you know, blood pressure's down, or look like they're tamping on and off, and next thing you know, they're gone. And then you can try and resuscitate them, you can get them decompressed and stuff, but it's been too late by that time. Tensions are always something that you keep in the back of your mind, especially when you see somebody who's going down and getting tachycardic, pressure's going down. It's something that you've got to kind of keep aware of. Collection of air trapped in the pleural space, yeah, that's the pneumothorax. It's usually not associated with hemodynamic instability. Like I said, a lung that collapses doesn't always say that they need to have something done. It can be usually due to lung injury. It can be iatrogenic. Do you know what that is? You caused it. Try to put in a central line, go subclavicular approach, nick the pleural area as you're going into the artery. There it goes. You did it. Some of the surgical guys, they enjoy that because then they think they can just get chest tube, get 2 procedures out of one. But to me, I kind of feel bad if the patient has that. But it's usually due to some type of injury, something happened. Doesn't really require emergent intervention like we talked about. You know, as long as you're stable and doing fine, you're fine. You don't have to just obviously stick a thoracotomy tube in them and go. You know. Thing is though, if someone does have a pneumothorax, especially if they come in the ER and they're stable, don't send them home. Don't do it, or just pull out your checkbook. Okay? They do need to be followed with serial chest x-rays. They can put on oxygen, they can develop into tension, which can be bad. Most of the time they just reduce themselves and then you're going about your business and no problem. Okay? So, I mean, on this one you can see, I mean, this is an obvious one. Sometimes they're not always obvious. You can see it on the CAT scan where it's down. I mean, I've looked at chest x-rays sometimes and I'm like, Jesus, I don't even see it. But they've been there, they got a CAT scan and look on the CAT scan like, how in the hell can you not see that on chest x-ray? Honest to God. Sometimes they're not, but I mean, you can see lung markings all the way out here, but you know, this is quite obvious on some of these, but sometimes they're subtle. Sometimes, you know, these 10%ers that are only about like right through here or something like that, very, very difficult to pick up. Radiologists always love to say, hey man, you missed this. Yeah, okay, son of a bitch. I only had 20 other patients I was taking care of at the time.
And he wasn't superimposed.
Exactly. Pneumothorax not seen on chest x-rays, truly occult or just missed. Well, that's that old adage, you know, that happened after we saw the patient. Or, you know, it wasn't there when we did it, you know. Sometimes it happens. Right? You're human, okay? And it goes back to the practice of medicine. You're okay to be human. If you do the right things, it's okay if you miss stuff. It happens. I've missed a ton of shit. Trust me. And I missed a hell of a lot more 20 years ago than I miss now, but I miss stuff. I miss stuff today. Or don't get my guidelines of what I need to be done, especially on like that SIRS crap. That's the biggest thing right now. I mean, I can show you emails being sent to me right now on sepsis protocols at St. Anthony's. We're at 50% compliance. The entire emergency department. It's better than the 0 we had, you know, about a year ago. So, I mean, you know, even my attendings, I mean, it happens. I mean, or you get busy. I mean, shit, when you've got 10, 15 patients on your board, and you got this, and you're doing it, you can't track the vitals all the time. I mean, you're doing the best you can, you're ordering lactic acid, doing all that. It happens. But, you know, you just you've gotta keep these things in your minds when you're going around seeing patients doing what you're doing.